EUS guided Hepaticogastrostomy. Myself, Dr. Sanoop Kumar Sherin Sabu.
She is a 68-year-old female with type 2 diabetes and hypertension, presented to us on September 2023 with history of obstructive jaundice due to distal CBD strictures. She underwent ERCP and CBD plastic stenting. She was advised for detailed evaluation in view of imaging findings suggestive of gallbladder malignancy, but loss of follow-up happened. On February 2024, she presented to us with history of vomiting but no jaundice. Imaging showed features suggestive of gallbladder malignancy with duodenal involvement and GOO and no evidence of IHBRD. LFT was normal. OGD scopy could not negotiate D1. She underwent diagnostic laparoscopy, anterior gastrostomy to relieve GO. Biopsy was taken which showed poorly differentiated adenocarcinoma. She was planned for palliative chemotherapy after general conditions were stabilized. On March 2023, she again presented to us with history of jaundice for 2 weeks and vomiting for 1 week. Clinical examination showed icterus and tenderness in the right hypochondrium. Investigation showed elevated bilirubin total of 18.5 with a cholestatic pattern of ALP elevation with raised CA 1999 and CEA. CT abdomen showed features of dilated CBD with moderate IHBRD with left more than right and gallbladder thickening suggestive of gallbladder malignancy and node involvement. CT PET showed features suggestive of primary gallbladder malignancy with lymph node involvement and enhancement in the second part of duodenum. Therefore, a diagnosis was made for obstructive jaundice secondary to hilar obstruction due to adenocarcinoma of gallbladder, TNM staging T3N2M1, AJCC staging 4B, and ECOG performance score 2 with GO with status post anterior gastrostomy. Further treatment plan for her in view of inoperable malignancy was biliary drainage and palliative chemotherapy. Transpapillary drainage is not possible due to D1, D2 obstruction. Biliary drainage for her in the presence of an IHBRD with a left dominant IHBRD, there are two choices. One is either a PTPD drainage for which the patient was not willing. Second option is an EUS biliary drainage procedure. Therefore, the proposed plan for her was an hepaticogastrostomy with and partially covered GOBA biliary stent to prevent bile leakage and stent migration with the proximal covered flanks inside the stomach and the distal uncovered part inside the biliary system. CT shows IHBRD left more than right with the previous stent in situ and gallbladder thickening and malignancy confirmed in the PET scan. Screening from OG junction shows dilated left IHBRD. Using 19 gauge EUS FNB needle, segment 3 was punctured. The fluoroscopy image shows FNB needle directed towards the center to the hilum. Previously deployed CBD stent is also noted. The FNB needle is advanced into the dilated bile duct. Bile is aspirated to confirm the position of FNB needle in the duct. Guide wire is slowly advanced towards the hilum through the left dilated hepatic duct, targeting the hilum of the liver through the left system. Fluoroscopy shows the direction of the guide wire towards the hilum through the left. 19 gauge needle is exchanged with French cystotome. GOBA nitius 10 mm into 10 cm stent is advanced in the left hepatic duct. In the endoscopic view, we can visualize slowly we push the stent forward. The fluoroscopy image shows the SEMS in the left hepatic duct being deployed. In the endoscopy view, now we can visualize the bile being beautifully draining out from the dilated hepatic duct system towards the stomach. This decompresses the dilated intrahepatic biliary radicals, and this step shows the immediate technical success of EUS Hepaticogastrostomy. In the fluoroscopy image, finally we see the GOBA nitius stent with the proximal end in the stomach and distal end in the left system, segment 3. On post-procedure day 2, the bilirubin of the patient came down to 6 from 18 and ALP also came down to 386. This shows the immediate clinical outcome of EUS-guided hepaticogastrostomy. Therefore, EUS-guided hepaticogastrostomy is a biliary drainage procedure with high technical and clinical success in cases of failed ERCP. Thank you.